Hello everyone and welcome. This is George McAllister with MCOL, and I'll be your moderator. We're glad you could join us. Our webinar today is Provider Coding Accuracy in Commercial Value-Based Contracts. Our speaker today is Dr. Rong, Principal and Healthcare Management Consultant with the New York office of Milliman. Before we get started, we just have a couple things to keep in mind. Our speakers will be taking your questions via the chat feature. While all questions will be addressed at the end of the presentation, you're more than welcome to send your questions now at any time throughout the webinar. To chat, please click the blue talk bubble on the bottom left-hand corner of your screen. And if you would like to receive a copy of today's presentation, you can download it from http://healthwebsummit.com/Milliman121317.pdf. Lastly, if you require any other assistance, please contact the HealthcareWebSummit office at 209-577-4888. Rong, we're ready for you to begin.
Great. Thank you for having me. Advancing the slide, sorry. So today, the focus of the discussion, this webinar, is really commercial value-based contracts, although a lot of these concepts or analytic frameworks that I will be presenting apply to other types of value-based contracts as well. So just a few words on sort of, why it matters. As value-based contracts become more and more popular, and so does the variability of the provider's overall compensation. So typically what we see in these kind of contracts is that providers are being measured on metrics, performance metrics, that will dictate how much they ultimately will get paid. And part of that payment is risk-adjusted in the sense that a spending target is based off of some historical performance, and then and that gets risk-adjusted to reflect the current mix of the population, and then comes performance year or years, and the actual performance will not get risk-adjusted typically, but will be measured against that spending target, and the residual, whether that's positive or negative, positive in the sense of there's surplus or savings to be shared, negative, there will be a deficit. So that creates variability on the overall compensation for the provider. So risk adjustment, therefore, plays a pretty important role in determining the financial outcome of the provider. So for value-based contracts to be successful, of course, and equitable to all parties, I think this risk adjustment, not only as a methodology but also as a pretty significant program operation, needs to be solid in the sense that data needs to be captured accurately, and the methodology should also be equitable in terms of measuring the changes in illness burden of the population. So that's why it matters. And before I go into the actual presentation, I wanted to mention a few caveats and limitations here. So Milliman, as you know, we're a consulting firm. So the material here I'm presenting only is for educational purposes. It does not represent any official opinions and should not be used as such that would lead to a potential misunderstanding of other Milliman consultants' opinions about the same type of issues. And it's solely my own. In other words, it's my own and does not represent the collective opinions of Milliman. And more importantly, third parties should not place any reliance on this presentation that would result in the creation of any duty or liability under any theory of law by Milliman or its employees to third parties. So in other words, it's purely educational. And the exhibits that I'll be presenting are purely illustrative and done on national data sets and does not really represent any specific client situation as well. So today, I plan on discussing how risk adjustment plays a role in provider contracts and what kind of contracts. And you will see fairly quickly that, in fact, risk adjustment has become a rather common commodity in risk-based deals, whether that's public program or a private insurance provider arrangement. And then going into it a little deeper into the construction or calculation of a risk score. So what does matter? So giving you a quick primer if that's not already a familiar topic to you. And then I'll move on to talk about some of the common data issues that we have observed in our that may impact risk scores. So what they are and how do we quantify the impact on the risk scores. And then along with those same lines, I will be presenting some of the sort of data points and metrics and frameworks that might be helpful to you in your practice as well. And then finally wrap up with some takeaways and big trends that I thought would be worth monitoring. And then we'll take questions in the remaining of the presentation. So the gist, as I mentioned, is that risk adjustment is actually a pretty important component in risk contracts. And as risk contracts become more and more popular, the importance of risk adjustment or the accuracy and how it's done, timeline, etc., are also fairly important aspects to consider as it affects your bottom line. And when we look at ACOs, just broadly speaking, there's like different types, public programs versus private programs. In Medicare, we all know there's the Medicare Share Savings Programs, and there are different tracks and using different patient attribution methodologies. But the risk adjustment methodology used there is the CMS HCC model, and which I can explain in a little bit. And then there's also the next gen. That's sort of the better, nicer and better next generation of Medicare ACOs that actually opens up bigger potentials for rewards or losses. And the CMS HCC model could also be a pretty significant factor there for next gen. And then there are Medicaid ACOs. These are all fairly state-specific. I can give you an example. In Massachusetts, for MassHealth, which is the Massachusetts Medicaid agency, contracts with provider entities or provider ACOs to cover the managed care population. And the model that state uses is a combination of medical diagnoses, enrollment, and social determinants of health factors. So they call it SDH, social determinants of health factors, and to account for the complexity of patients living in certain geographic areas and sharing certain socioeconomic characteristics and receiving different other kinds of state benefits. So that's a pretty unique risk adjuster. And then there are other states that I'm aware of, such as Illinois, that uses open source CDPS systems for Medicaid ACOs as well. Although it's calibrated specific, recalibrated rather, specific to the state's population. And then we have the duals ACO, which actually was an intention but withdrew by CMMI, so the Center for Medicaid Medicare Innovations. There was originally a letter of intent that was issued to all the states, but due to lack of interest, I think that what I've heard was CMMI actually only received one letter of intent to start a program in 2019, and they did not receive it for 2018. Therefore, they withdrew from the program here. So, but the intent here is pretty clear that Medicaid, Medicare, dual eligibles could potentially also be wrapped under an ACO. And then finally, the focus of today's presentation, the commercial ACOs. The commercial ACOs are arrangements that are between the private payer and the provider systems that they contract with. For example, in Massachusetts, the Pioneer here is the alternative quality contract rolled out by Blue Cross Blue Shield of Massachusetts. That is risk adjusted. It involves more than 12 dozen systems nowadays, and it's been closely studied, and so far I think I've read some articles about the efficacy and the cost sharing, expenditure trend bending kind of an effect that has already taken place or documented by the program. That program uses a proprietary system called DXCG, and it's also a fairly commonly used system that's specifically developed for the commercial markets. Okay, so we'll move on. In the next segment, I will talk about the structure of risk scores, how it's calculated, and so on. I think it's important to understand that risk adjustment so far has mostly been based on administrative data, so namely age, gender, number of months enrolled that you could identify from the data, and then also the enrollment categories. So the enrollment category, such as low income and disability, those are the factors that show up in the Medicaid ACOs or in the CMS HCC model that's used by Medicare ACOs. Disability also is a factor in the Medicare risk adjustment for Medicare ACOs. Disability and low income are both important factors in Medicaid as well. So those are sort of the information that people could obtain from administrative data. And then claims, namely medical diagnoses on medical claims and NDC drug codes on pharmacy claims. So so far it's been mostly based on administrative data. The reason for that is it's widely usable, available, and it's standard. You can have the same data format on the same set of people year after year after year. It makes it really easy to calibrate models and to monitor trends and so on. Although in recent years, I think it's worth pointing out that there are some encouraging movements or advancements in risk adjustment, such as using the combination of diagnoses and pharmacy data and the inclusion of socioeconomic data in risk adjustment. So as an example, the HHS HCC risk adjustment models, which are the commercial risk adjustment models used for the commercial, individual, and small group market for fund settlement. That model, starting in 2018, would include prescription drug classes as part of the risk scores. And the rationale there, which actually plays very nicely into this presentation, is that there are data issues that in practice patients would, with the chronic conditions, could be managed using prescription drugs, and either physicians don't code them or forgot to code them, or that the care was provided through a prescription renewal. And so during that year of observation, you may not see a diagnosis, but nevertheless you see the prescription drug that's specifically indicated for the medical conditions. So CMS for commercial risk adjustment in 2018 decided that it's to be equitable across the market. Commercial plans risk adjustment could also be the risk scores could also be inferred from pharmacy data, although in a limited way, and I'll explain a little later. And I've already mentioned the socioeconomic data that's used by Massachusetts Medicaid program. That's an interesting thing to watch, especially in Medicaid, because we know that care, delivery, and efficacy, and patient compliance, et cetera, all the sort of behavioral stuff is heavily influenced by the socioeconomic factors at the patient level. So to the extent that a risk adjustment model could reflect these important factors that would influence cost outcome, and to the extent that the payer would be able to adopt such a program in setting program payments for the ACOs. I would think that this is actually getting not only more accurate but also more adequate payment for those who are treating a disproportionate share of sort of lower socioeconomic status patients. One word of caution is that socioeconomic factors are typically harder to obtain, and also typically is not widely collected on all patients. So that remains a challenge for both the payer and the model developer. So that's that. The output of these models, using demographic or medical or other types of information, the output of the model is a member-level risk score. So let's say that the risk score is 1.0. So what does that represent? 1.0 actually represents, in a relative sense, that the member, 1.0 member, is expected to be the average spending for healthcare resources for a reference population. Let's say that in the commercial setting, the average patient typically was slightly, like almost 51% of the commercial data is female, and age around 33 or 34 of an average expenditure these days probably anywhere between $350 to $400 PMPM per member per month, with a set of characteristics of utilization. So if I have a patient running through the risk adjustment model that I get a 1.0 risk score, the patient will, in attribution, or not in attributes, will be similar to that patient. And in other words, my 1.0 patient is expected to cost on a PMPM basis between $350 and $400. And then a 2.0 patient, therefore, is twice that number. So it's 2 times 350 or 2 times 400, so anywhere between $700 to $800 PMPM. So that's how it works. Once you have a large number in a group, a large number of patients, then you'll be able to calculate the group average, and the group average in comparison to other groups' averages, or in comparison to this group's prior year's averages, and that establishes the relativity of the whole system. And money actually gets flown based on the magnitude of these relativities. So, and then the question is, well, how is the risk adjustment system really calculating the risk scores? So here's the flow chart. I hope this is legible here. It goes through a production system. I think it's important to keep in mind that the production of risk score is a production that takes time and takes many different steps and involving different departments and maybe different entities at opposing interests even. But to summarize, if we were to only limit our view within produced claims or adjudicated claims, the claims would come in. The claims would contain so demographic information, enrollment data that I mentioned, so age, gender, and disability, low income, et cetera, and then medical diagnoses, so ICD-10 codes these days, and prescription drug data. In some systems, such as HHS, HCC, starting in 2018, prescription drug data would be part of the model. And in some other systems, such as the open source Medicaid plus RX system, that's also used as an input. The important thing here to note is that not all diagnosis codes are counted toward the risk score. First, we'll go through a filtering process. In a lot of client work, I have seen that this filtering was not paid much of attention to, or it deserves actually a pretty significant review here. At the high level, not all diagnoses count means that it has to be a clinically valid and confirmed diagnosis coming from someone that can code it with good credibility. So what does that mean? Lab tests and radiology claims typically carry the diagnoses codes that are meant to be ruled out. If so, they should not be. They're meant to be ruled out. So the credibility of the diagnosis therefore need to be questioned. Therefore, these claim lines typically are not used for risk adjustment scores. And along the same lines, things like DME, transportation, and other ancillary services, typically, sometimes you do observe diagnosis codes coded on the claim line, but they are typically not documented by a sort of a clinician with the right kind of credentials. Therefore, they're also not used for assessment. And in Medicare, for example, we also know that these so-called low-intensity care sites, such as home health, and questionable in terms of whether or not they carry medical diagnoses. So the gist here is that not everything counts. It needs to be filtered out. After filtering, we typically see that 40, even 50% of the claim lines could be removed as a result of that. Of course, that varies by utilization and also varies by how much bundling the claims are coming from a provider system. But it's a very significant piece. It should not be treated lightly. In other words, when you're doing your own risk adjustment calculations, it's good to follow the standard filtering methodology, such as those that used by CMS for either Medicare or for commercial. And it's all in the public domain. After filtering, in the second stage, the age, gender, enrollment categories will be created. So these are what we call dummy flags. So yes and no flags of whether or not that member is in age 0 to 1 male or 35 to 44 female, and so on. And as well as medical conditions here. Medical conditions in the middle typically varies by system. So as I mentioned, Medicare uses Medicare's CMS HCC model, and that model on its own had also gone through its own evolution of higher numbers of HCCs being included and different sets of coefficients being included and so on. So that it's an ever-changing system. The Medicare models are different than those used in Medicaid, and which are also different than those used in commercial typically. So the medical conditions is a way of, so from the medical diagnoses codes to the conditions, there's this grouping of clustering of diagnosis codes into clinically similar conditions. So for example, these I'm just making up, let's say these 20 ICD-10 diagnoses codes for diabetes with minor complications are going to go into one category that's called diabetes with complications. So this level of aggregation creates a medical condition of yes and no. And you can imagine that after the grouping, each member would get one or maybe 0 to multiple flags of medical conditions, indicating the comorbidities that they have. In a similar way, the NDC codes get grouped into drug classes. There are, again, different ways of clustering NDC codes. And the challenge there, from a model designer's perspective, would be that NDC codes change. Actually, the code set changes fairly frequently. New codes get added, thousands of them every year. And in existing code sets, the same NDC codes could also be used for, or same drugs rather, could be used for treatment of other conditions off-label. So there's a lot more updating that would be involved in aggregating the prescription drug data. So after the second stage, if you think from a data perspective, each member would have a set of age, gender, yes and no flags, eligibility flags. And then in the middle section, in the medical conditions, there's also multiple yes and no's for diabetes, CHF, et cetera, et cetera. And then for drug classes, it's also like anti-diabetic drugs and loop diuretics and so on and so forth. And then comes to this part, the third stage, risk weights and member months adjustments. So this is sometimes a proprietary mechanism, sometimes not. In the case of the systems used in the public domain, Medicare, Medicaid, the risk adjusters typically have been public open source models in which you can actually see how much a factor such as age, gender, or such as diabetes as a medical condition, or such as anti-diabetic agents as a separate drug class, how much additional risk weight is worth toward the final member level risk score. And there's some other smoothing that I mentioned here, in particular member months adjustment. That actually is a feature in the HHS HCC model to be used for the commercial risk adjustment for the commercial markets. And when you have everything weighted, and then the member's risk score gets added up, say again in my example, the member with that particular age group will get a risk weight added toward and added with, say, the member's risk score coming from diabetes and coming from, say, congestive heart failure, COPD, and so on, all these conditions added, and then doing some eligibility smoothing, and it becomes the member level risk score. So these systems are largely additive. There's some small spins to it, but mostly it's additive. So with knowing the build-up of the risk scores, then you can easily see what matters and what drives the risk scores. So we certainly know that age, gender does, and enrollment status, socioeconomic status if it's used. But most importantly, in the market right now, if it's a diagnosis-based system, the biggest drivers of risk scores are medical conditions. Okay. And I do want to mention that the complexity here is if you're an ACO, you might be in several different ACO payment risk contracts with different payers within the commercial domain, and you could also have Medicare and Medicaid, different deals there too. And different payers could be using different risk adjustment systems. Overall, it's just fairly complex to manage from a data perspective, from a settlement timeline perspective, in terms of how frequent it is that you would be getting data from interim settlement results from your payers. They may be using different runout. They may reconcile things differently, and so on and so forth. So it's fairly complex, and risk adjustment on its own is a fairly complex system. So the whole complexity gets multiplied if the different payers are even using different types of risk adjustment systems. So overall, it seems like a fairly daunting task. So if we were to start from somewhere, I guess people want to know if there is a general approach that I could use to identify issues that I should be concerned about that might impact risk scores, regardless of payer and regardless of the risk adjustment model that they chose. Here's some general ideas. Well, there are different data issues that we have observed that are fairly common. So number one being that the providers did not include all of the medical diagnoses on the claim line, and either because of data limitations, the data collection system limitations. So for example, the system only collects one diagnosis field or only has one field for you to fill out a claim. or that the physician who did the coding did not remember to code everything down on the claim. So that could potentially result in a reduction in risk or an underestimation of your true health status. The other is that is the level of precision. So what I mean by that is, if you look at the ICD-9, and now these days ICD-10 codes, there's the root code. So the most common being 3 or 4 digits. In fact, 4-digit ICD-10 codes are fairly common, being the majority. And then the 5th, 6th, and 7th typically represent things like complications and indicating severity and other factors that so a subsequent episode or initial episode and things like that. That could help determine the severity of the condition, therefore could also trigger a different medical condition within the risk adjustment system that has a higher risk rate. So if a provider did not code to the right level of precision, the severity may not be properly indicated. As a result, could also understate the risk score for the population. And then there are 2 other things that we also typically look at that have even greater impact. Number 1, actually number 3 on my list here, is that chronic conditions may not be coded year after year. In fact, this is fairly common. And then the second is that there are prescriptions that were in the drug claims that you could observe for which the drug classes are used specifically, exclusively treating certain medical conditions. But when you look at the medical claims, you do not observe the same medical codes written down for a variety of reasons. So that also has a pretty significant impact on the risk scores. So from a magnitude perspective, these are all approachable problems that will make a difference. So that's why this talk is really focused on these 2 remaining issues. I do want to make a important note here that when there are these things are called chart reviews, when you do chart reviews, trying to identify missed opportunities, and you should also keep in mind that the chart review could also go the other direction that would result in the removal, exclusion of an existing diagnosis on the medical claim that is not supported by the underlying medical chart. So a chart review actually could go both directions. I think it's important to know that. So here, going into a case study here. So we actually had taken the 2014 and 2015 market scan. Market scan is a fairly well-known national benchmark data set for commercial claims, and also a combination of market scan and the Milliman's own contributor health source database, the CHSD. This is a proprietary data. The size is comparable to market scan. As well. The layout and so on, they're all fairly consistent. So we actually took the Massachusetts portion of the combination of data sources, so from market scan and from CHSD. The reason for looking at Massachusetts is because Massachusetts as a market collectively has seen higher concentration for commercial risk contracts. So we wanted to ask the question, in an environment that's sort of seen risk contracts in the commercial space already, what's the opportunity there in terms of coding? And then we also selected members who enrolled continuously for 2 years, in which I'll explain why we did that, because we need to look back 1 year to find gaps in coding of chronic conditions. And then we require that the member has to have medical and pharmacy benefit. This is so that we could use pharmacy claims to identify missed opportunities on the medical side. And then we have some data member requirements, basically to ensure that the data that we're selecting is comprehensive and does represent all of the claims that the member had seen and all of the good quality data, I guess, that we would expect to start with. The first thing we look at is this thing called coding persistency. So what I mean by that is a medical condition, a chronic condition, let's say a chronic condition such as asthma or COPD or congestive heart failure. These conditions do not go anywhere. It's typically managed, but they will unlikely get resolved. So conditions like that are expected, from a risk adjustment perspective, are expected year after year. They could go up, they could go down in severity, but they should not be disappearing. In claims, however, in practice, we have observed that year to year, a condition that's chronic showing up in the first year may not get coded again for the same patient in the next year. So that, the question is, what does that mean? Does it mean that the patient did not get treated? Does that represent a quality gap in care delivery or a lack of patient engagement and so on? So not knowing the actual reason, but at least we know that there's a gap, and it certainly will have a material impact on the calculation of the second year's risk scores. So therefore, it's important to understand how prevalent these persistency issues are and what they do on the risk scores. So here's the methodology. We used, so for the 2014-2015 market scan and CHSD data, we applied the commercial HHS-HCC risk adjustment model. So this is an open source model. It was developed on commercial data, and it contains the mapping that would apply to these 2 years. Remember that in 2015 we had the ICD-10 conversion. And then we also selected this model has the hierarchies such that the most severe condition would be recognized, and it will trump over less severe conditions. Here's the example being that diabetes, the diabetes with complication. In this case, if it's observed within the same year with the same condition, so diabetes without complication. And if both were observed during the same year, the one that's more severe will trump the other one, so the other one will not get credit in the risk score system, and then the more severe one will. Okay, and then we also looked at the most significant prevalent conditions in the system, so that, most significant meaning that it has the highest risk rate, and most prevalent means that a lot of people have those conditions. And then the idea is that if it was a chronic condition that was coded in the first year, we want to know, yes and no, it was continued to be present in the second year. So what do we see here? We saw here, for example, we selected only for the purpose of this webinar, we only looked at these 9 conditions, the HIV, end-stage liver, et cetera, et cetera. So these are pretty serious conditions. And you can see in column A, we looked at the risk weight. So we actually had to take within the HHS-HCC model a weight that would apply most appropriately for our population. So this is the adult model, gold is a metal tier, gold tier risk weight. So you can see that everything else equal, the patient with HIV/AIDS would have an additional 4.972 worth of a risk score added to what else the patient also has. This is a very significant condition, very large in risk rate. And end-stage liver is worth of a 6.1, and here you see MS, multiple sclerosis, and that's 6.9, almost a 7 of a risk score. So to put things in perspective, if my average spending of a member 1.0 is 350 to 400, and 4 times or 5 times, 6, 7 times of that number is a fairly substantial expenditure, and that seems to be at least directionally consistent with the treatment costs required for these conditions. So then knowing that they're pretty significant and chronic, so let's take a look and see what the persistency is. The persistency is calculated as, asking the question, how many people were coded with HIV, say, in year 1? And of those same patients who continue to be coded in the second year, we see that there's actually quite a variation. The lowest on the map here is end-stage liver. So patients, 47% of the patients who had that diagnoses or HCC in the first year continue to have that same diagnosis or HCC in the second year. The question is, where did the other 53% go? Right, knowing that it carries such a significant risk rate for the population. And of course, it's with things with HIV/AIDS, that's a condition that's not going to go anywhere. What happened to the 9%? You might wonder. The patients who drop off the radar. So and then naturally you can see with a bit of a drill down analysis, you could actually identify the patients and their treatment providers, for which then you can send them reports, reminders, or questions and asking about the coding. Where did the diagnosis go? And that will help you improve the accuracy of data and risk scores. So putting it together, the hypothetical question is, if for these 9 HCCs that we're looking at, just on those 9, by the way, if all of the coding holds in terms of chronic conditions, if all of the dropped chronic conditions in the second year were patched up, what does it do to the average risk score? So here we're seeing a 2.9% of increase in risk score. That is material and it's meaningful. It could be someone's profit margin already in this day and age. So that's one analysis that any organization might be able to do. The other analysis, which is, so the first analysis requires 24 months of continuous enrollment, so a look back into the past. This analysis is looking at the correspondence between diagnoses and prescription drugs. Does not require a look back, but it does require a pharmacy claim. So the idea here is that there are there are patients who are treated with prescription drugs but did not have a medical diagnosis that the drugs indicated. So in that, because if the system only takes in diagnosis information and only counts that, so what this could also lead to a reduction in risk scores. So how do we quantify that? What are the conditions that seem to have these kind of one-to-one inference or correspondence between prescription and drugs? So we actually look at these 8 drug classes. So there are specific drugs for hepatitis C, specific ones for HIV/AIDS, and for diabetes, so on and so forth. So you can actually look up any drug database, and you'll be able to find these drug classes fairly easily. And here we're also showing that these conditions in column A, these conditions are material and pretty substantial. I think even though cystic fibrosis is a fairly rare condition, it's still a pretty large risk score in the model. And we are seeing that within the year, if using medical claims, we were seeing like 2.3 count of patient out of 10,000. But if we also look over to the pharmacy claims, we could actually increase that prevalence by about 0.2%. So column B is the prevalence based off of diagnoses on medical claims only. Column C here, on the other hand, looks at the combination of diagnoses and drugs, and the addition is the enhancement that comes from the drugs. So how much is that worth in terms of risk scores? We're seeing in our analysis for this particular set of patients, we're seeing about 3%, 3.1% of the increase in risk scores. To put things in perspective, what we saw from the dropped chronic conditions analysis, that's in addition to the missing HCCs. So we're really looking at, perhaps 5-6% potential of improvement, looking both ways. So that is a fairly substantial increase in the risk scores. I wanted to still mention that this is a theoretical exercise. Not all of the improvement can be achieved all at once on all patients. So it does take some time to get to probably a reasonable number that's probably between 0 and 6%, given our analysis. And the other thing I want to caveat here is that we only looked at a subset of HCCs and a subset of medical drug classes that are used to treat exclusively for medical conditions. There may be other opportunities, and there are certainly a lot other services that's out there in the industry that people have procured to improve data quality and for risk adjustment. There's actually a whole industry out there, almost a service industry out there to help people improve risk scores. What we're showing here is for illustrative purposes only, and it may or may not be replicable on your data. So wanted to take a few minutes to talk about some important trends that's worth monitoring, because it might sooner or later impact the commercial contracts. The commercial contracts have been, commercial risk contracts actually have been looking at Medicare ACOs and Medicare risk adjustment as a reference point. So anything that happens that will that impacts Medicare risk adjustment potentially would create ripples in the commercial world as well. And it's also that sometimes the commercial space moves a bit ahead than Medicare risk adjustments. For example, the use of pharmacy codes in commercial risk adjustment, that has also been discussed in the Medicare circles. So these two are actually running somewhat in parallel. So that's why it's important to actually look both ways. So for all risk adjustment programs, whether it's Medicare Advantage or Medicaid managed care or ACOs of any kind, I think it's important to know that risk scores come from a very long production of data and calculations, and this system is fairly complex and takes time. Any step in the way, there may be inaccuracies, it could be data issues that will result in inaccurate risk scores. So if you as a provider entity, you're only sitting at the very bottom of the very end of this production chain, you're receiving data from your payer, this may not be helpful. So my personal experience has been that if you're an ACO, the best is to get the data, get to the bottom of this production chain to make sure that every step in the way there's no mistake, there's no leakage. And then to get ahead of the game, try to understand the risk adjustment systems and understand how it's calculated, and to make sure that you can reserve properly, you can anticipate risks, and you can anticipate surpluses and deficits appropriately in your financials. And it does have a pretty significant impact. So in terms of impact, we can see here. On the chart here, I'm showing what we call a coding adjustment factor. This is a thing, or a mechanism implemented by Medicare to control the fact that data quality gets better, risk scores improves over time for Medicare Advantage relative to the fee-for-service population. The gap between Medicare fee-for-service and Medicare Advantage, therefore, according to CMS, it can be largely attributed to the fact that Medicare Advantage is being risk adjusted. Therefore, there's a lot of incentive for payers to code better. So as you can see, the coding adjustment factor has been going up gradually year after year. And as we speak, it's close to 6% already. In fact, it's like 5.9 some percent annual. What that means is that Medicare Advantage plans would not get more payment if their risk scores are moving up year to year within that 5.9% increase. You have to go more than that in order to receive higher payments. So what does that mean? It means that you have to keep running. If you are a new health plan, you have to keep running in order to stay the same. But it also means that at least coding improvement may result in a substantial increase in risk scores, and the payers are fully aware of that. And at least in Medicare, there has been a mechanism to aim to dampen the impact of better coding. And we have seen in our practice some of the commercial contracts also have some kind of a coding adjustment factor mechanism built in, and it's subject to the payer and the provider. It's not everywhere. Even with the same payer and the same in the same market, the payer may use a different coding adjustment factors with a different ACO. And it seems to be an area of business negotiation. But the reason that I'm highlighting the importance here is that coding adjustment or coding intensity has been observed and has been there are ways the payers can implement mechanisms such as the adjustment factor here to dampen the impact. So from a provider's perspective, just like Medicare Advantage plans, you need to stay running on your data quality in order to stay the same. And then, so the MedPAC proposals, there's some of the proposals that are fairly interesting, which I think will, down the road, play in, maybe change how the risk adjustment methodologies are constructed or conceived. One thing is that they proposed, knowing that chronic conditions can drop year over year, they said, well, instead of collecting data just from 1 year, why don't we expand it to be 2 years? If that should happen, with 2 years of data, remember that we had a graph, an exhibit that shows the different percentage of coding persistency. Just bring it up real quick. Here. This is all within a year, right? So in the second year, 91% of HIV patients continue to be, coded as HIV. If the horizon gets expanded, then in theory we would catch within the 24 months all of the HIV patients, all of the MS patients, and so on and so forth. And then instead of imposing a artificial coding adjustment factor to dampen the impact of better coding, why can't we change the methodology so that it's more flexible and work with the imperfect data? Let's expand it. It sounds pretty interesting from a methodological perspective, but there are some practical challenges there, such as data collection. It does require going back 24 months, and not in Medicare, not everyone would have 24 months. So what do we do with patients or beneficiaries who become 65 in the middle of the year, so they will become partial, and so they have no prior history, and so on and so forth. So there are some practical challenges there. with respect to that. But it's an interesting trend to watch and see how exactly or when Medicare will be implementing that. And I think that another thing to watch is that at least in the public programs for Medicare, for the commercial individual and small group market, HHS is doing a combination model, some combination of diagnosis and pharmacy model, and that they argued, several benefits of using pharmacy and also the limitations of using that in some prior publications. The gist is that this could potentially also impact how the commercial ACO or risk adjusters are thought of. Remember that we had shown in the other analysis where there's a lack of correspondence between drugs and HCCs, or drugs and medical diagnoses, and which is a data issue that could potentially be patched up, but that's worth about a 3% gap. If that gap can be covered by this hybrid model, then perhaps, meaning that the methodology now is more accommodating with respect to a lack of perfect data, then the gaming opportunity, the improvement opportunity of 3% may not be there anymore because the claims will take care of themselves. So that's another trend to watch. So that's all for the presentation, and now I'm open for questions. Chairperson, should I just read the questions that came in?
Yeah, you can just go ahead and read it.
Okay, so this comes from the chat box. Other than suspecting diagnoses, please explain how pharmacy claims come into play. Is there additional revenue other than the accurate coding of condition? I think we've addressed that as the second part of the sort of the data analytics already. So pharmacy claims do carry values if there is a clear indication from pharmacy, of course, to diagnoses. So we've already addressed that. This was probably typed while I was going over the dropped chronic conditions analysis.
We can give it another minute for if anybody's typing questions before I wrap it up. Alrighty, I guess that was the only question there. We'd like to take this opportunity to thank our speaker and all the participants for joining us today. We'll be sending a follow-up post-event feedback via email before close of business today, and we'd love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.